Hey Faris, thank you so much for joining me on the Business of Healthcare podcast and our series, How It Got Commissioned. Would you be able to share who you are and a little bit about what you do?
Well, hi Tara. Thanks for having me. I'm Dr Faris Al-Ramadani. I'm a GP partner at St Wolfston Surgery in Southam. I used to be a PCN clinical director as well, and I also work with health tech companies on a consultancy basis to help them develop their product and implement their product in the real world.
Thank you. So this series is designed to give people ideas and inspiration and top tips on how to get services commissioned. Would you be able to share us your example of a service that you got up and running and got commissioned?
Yeah, sure. Now, commissioning is a big word, and we were talking about this earlier, weren't we, Tara? So from our side, so when I was working within the primary care network, it became really obvious that there was a sort of an unmet health need. And that need was around the COVID pandemic time. And at that period of time, there was rising demand for mental health services. We were seeing actually more patients coming and visiting us with the sort of mental health impacts of COVID at some stages than COVID itself. It was a really, really high burden. People's mood was low, anxiety was high during that sort of pandemic and lockdown period. So much so that we were dealing with lots of patients with mental health problems, but it felt like we didn't have enough to offer them. So talking therapies, or IAPT as it was at the time, was sort of the go-to service. But because of the demand, the waiting times were getting longer and longer. And also at that period of time, we were realizing that there were many people that had a barrier to accessing IAPT and talking therapy services. So they might have been working people, so they couldn't access care during the daytime. They might have lived far away from where those appointments were taking place. And some people perceived a barrier, a distinct barrier between the GP surgery that they knew and trusted and an external provider who they'd never heard of and knew nothing about. So for many reasons, we found that we were struggling to get patients who needed, for example, psychological therapy, the therapy that they needed. And that felt like we weren't really giving patients the quality of care that we wanted to. And that's where we needed to think of a solution. So I suppose good commissioning is probably born out of identifying a problem. So first of all, we identified that problem. And then it was about trying to build the solution. Now, I suppose in normal commissioning routes, the solution is that you develop you develop something that you need delivered, and it goes out to a tender. But obviously, because we were a primary care network, we were GP surgeries, we could actually deliver that ourselves in-house. So we could almost, if you like, remove the tendering part and just try and connect the problem with a solution. And that's what we did, and that felt like the right thing to do, particularly with primary care networks as they were and they are. It's about using the resource and the tools that we have within primary care so that we can better address those needs and meet those needs of patients. But also, as a primary care network, if you're able to do that, you can actually remove demand from the GP surgery as well. So if you can steer patients to new solutions and new pathways, you may reduce demand within primary care and GP surgeries more specifically. So that's where the journey began.
How big is your primary care network?
34,000 patients approximately.
And how many practices?
5 practices.
Did you receive any pushback? Did any practices say, I know that this is important, but resource is scarce and it would be better placed somewhere else? Or was it unanimous that this was a problem that everybody wanted to solve?
I think at the time, the practices were all really good, to be honest. I think it was a clear problem. And actually, I think, the practices were very willing to listen to solutions that were able to help with that problem. I think what was really interesting was we managed to do a lot of this work on very little resource, which was really interesting at the time. So we basically started off by approaching local colleges who were training psychological therapy trainees and asked if they wanted to do their placements with us rather than somewhere in a private company or somewhere else. So we could unlock immediate capacity. We had GP trainees, so why not have psychological therapy trainees? And they were overseen by the college and by the college tutors. So that was quite an interesting way of bringing in some capacity. And it also, at that period of time, the logical thing was, why don't we use more digital? At that time, everyone was shopping on Amazon, everyone's doing Sainsbury's or Tesco's or whichever supermarket you choose, they're getting them to deliver their food for them. So everything was being done through digital means through the pandemic. So why couldn't we do the same with a digital solution for mental well-being? So we partnered with a digital mental health creator and deployed their solution within primary care. So we were able to give patients immediate access to care through an app. And through digital means. So it kind of broke away some of those barriers, and that we could just do internally. So it wasn't creating a great burden within the primary care network or the GP surgery. So we were managing to recruit resources that were going to help in primary care and GP practices, but that were not actually consuming our own resources. So in that sort of situation, you end up creating sort of a bit of a no-brainer, really.
Yeah. And where you say it was a clear need, how did you evidence the need?
We all had the evidence ourselves because we were seeing patients who we said, you need psychological therapy, and they were coming back and seeing us 2 weeks later to tell us that I've been referred, but it's going to be 12 months before I get to speak to anybody. So the need was very, very real because we were seeing it because our clinical capacity was being used up through people struggling with their mental health, but we were also being told by those same patients that they were having to wait a long period of time for their appointments and their therapy. So the need, I think everyone kind of understood that need was real and there. So I think it was more that we could all feel that, really.
Whilst I think many primary care networks have developed their own services, another perspective could be we should be paid extra to do more. What's your view on that?
Yeah, and that's probably true. I think sometimes it's about just reflecting on the resources that you have available. So if you have resources available that can meet the needs or address a need or address a problem, and with a bit of creative tinkering, you can find ways of increasing capacity and resource without having to consume money, for example, then actually it starts to, again, you start to create a bit of a no-brainer argument. It is probably true to say that there would have been an argument for, well, why are you building a solution to the mental health problem in primary care when there's a mental health trust that could do that for you? And maybe that's true, but I think we have a unique privilege in primary care and general practice where we can see the problem immediately. So we're not waiting for someone else to highlight a problem. We see it because we're seeing the patients, and the patients are telling us their lived experience. So we can see that problem immediately. And actually, sometimes you can fix problems relatively easily and relatively cost effectively, whereas we could flip around a solution very quickly and a very effective one. But actually, if we had to reach out to a mental health trust or somebody else, that's very time consuming, can be a very costly process. And actually, we were witnessing a real time problem, something that was there and then right at that moment in time. So it became straightforward enough to do it. You could argue we couldn't, the concept of piloting, for example, we can pilot solutions and prove they work. And if they work, then we can seek funding perhaps to then get that properly commissioned or at least properly funded. But sometimes you've got a chicken and the egg situation where you've got a great idea, you see a need, you think you've got a good solution to the problem, but actually you need to evidence the solution, right? So unless you can evidence the solution, who's going to buy it? Unless you can prove what you do works, who's going to buy it? So sometimes you just have to get on and start creating the solutions in the hope that actually you'll generate evidence, you'll generate a new pathway, you'll generate and unlock some new efficiencies that actually people might be interested in. And actually, if this works well, then actually secondary care might actually be interested. The mental health trust might be interested. Unfortunately for us, they were interested in the work that we were doing. So the evolution of the hub was really, really fascinating because it started by recruiting a few new services that were then giving patients a greater menu of options so they could access care more quickly and more directly. But we were then able to, as we built more services and stuck more bits onto this, we then started to think, well, rather than a GP having to remember that they can go to cruise bereavement services if it's a bereavement, or they can go to use our digital mental health app if they wanted to, or they could see a therapy trainee if they wanted to, or a counselling trainee. We then recruited Mind as well, a Mind Active Monitor. How is a GP going to remember all of those different things and deliver that in a 10-minute appointment? It was impossible. So then you start thinking, well, why don't we centralize the offer? So why don't we create a hub? So we have a hub, which is led by, say, a care navigator or a care
Yeah.
coordinator who's able to speak to a patient and say, look, you've got this, and this. Which one do you want? And I'll help you get into it. We brought talking therapies into that equation so that our care coordinator was able to do a bit of the assessment in terms of just scoring, symptom scoring the patient, so that we could then link the patient into talking therapies and actually directly book them in with talking therapies rather than the patient having boundaries and barriers to accessing that care. So if you imagine all these different services, all kind of out there, we were trying to bring them into one place where there was one coordinated person that knew what was going on, and the patient would just get directed directly into that service with no additional referrals or anything like that. So you start to create this sort of hub model of working. So then, hopefully, if you've developed something that works and you can evidence, then you've got something that's maybe commissionable or externally financeable.
Is that hub still in place today?
It is, and it's still working very well.
Brilliant. So would you be able to share who were the key people involved in getting the service off the ground? Because there's something about capacity. So at the time, as a PCN clinical director and a GP, going to loads of meetings, it's like, where do you find the time? Like, who helped you get this off the ground?
So it starts with the clinical director. And within our primary care network, we had a manager, so the PCN manager. So by having a clinical director and a manager, you already had that resource, that time that you had working within the PCN to start to work that project up and work that plan through. So that's a really important nucleus. But beyond that, it was about having members of the PCN team, the ARS staff, who were also willing to look at this and find solutions and find ways of operating this sort of model. So we actually had a really, really engaged ARS team who were absolutely brilliant at coming up with ideas themselves. So they were actually driving a lot of the ideas too. So you were kind of co-developing between the clinical director and the PCN manager. Then you were co-directing it and co-developing it with the PCN staff, which was great.
Yeah.
But then actually one of the big parts here was those people who were interested, the digital mental health developers, talking therapies, you could start to talk and have those conversations with them too. So they were part of that solution too. We were working together to identify how we could create a frictionless system of having a hub model and referring patients into another service with no friction at all. So it was that sort of collaboration that made that happen. Now, obviously, that would not have worked if it wasn't for the support of the GP surgeries as well. So the GP surgeries were also, although they didn't have to do that sort of work in terms of developing it, they could at least give that endorsement and give sort of the PCN the direction that it needed and the validation that this was a project that was worth following through.
That endorsement and validation is so needed, and because if you don't have that, you can have the greatest idea, but it's just not going anywhere, or you're just you're dragging it along. So I think that endorsement is so important. Did you make any mistakes along the way?
Yeah, you're always going to make mistakes, aren't you? So there's always going to be things. And look, and sometimes it's about reframing that, are these mistakes or are these learning opportunities? And sometimes it's about getting that right. So in that sort of situation, the idea was clear, and I think it's as clear today as it was back then, to be honest, that mental health needs good, robust treatment. It needs quick and easy access to services. And even today, that's still not always the case. So the fundamentals are absolutely right. The problem that you're trying to solve is, unquestionable. So that's the easy part. The tough part is trying to create the solution. And it's probably in the solution where you will make mistakes or things won't necessarily flow as well as you want them to flow. And that will always be an issue. And I think it's hard to identify one thing, but you've got to have a mindset that's about continual iteration, and you have to constantly be willing and open to just changing the way and the model that you're using. So I can give you an example. For example, when we were working with talking therapies, we said, well, let's have one talking therapy practitioner, and that will be our network's practitioner, and we'll put all the appointments through that one practitioner. Well, we started to do that, but then we ended up in a perverse situation where we were actually extending the time it was taking to get the people treatment through talking therapies, because we were just relying on one person. So we thought we were creating something really good, and we were from a patient's perspective, because the patient journey now would be that they'd see a GP, the GP assesses them and says talking or psychological therapy will be great for you, I'll book you in with the care coordinator. And through, we were using EMIS, and through EMIS we set a PCN hub, so we were able to directly book that patient into the PCN hub to have that conversation, and then they'd have that conversation, and then that person in the hub would forward them and refer them directly to the service. So from a patient side, it was completely seamless, completely integrated, which is kind of where care needs to be going right now. But going back to that, having just one therapist that we insisted on created a bottleneck. So we then had to go back, look at that, and work with talking therapies to open up more practitioners, and maybe, be less firm on the idea that we had to have our own practitioner. And by doing that, we released the bottleneck and things flowed better. So it was constantly, you'd keep identifying things that you could do better, but it's that willingness to change and innovate and diversify that made the difference.
What would be your number one tip that you would give somebody looking to develop their own service without the reliance on a commissioner commissioning it?
I think it's about just being brave and being bold. If you've got a problem that you can identify in your community, in your population, and you have some resource available that means you can create a solution, then I think you go for it. I think you just be brave and confident enough to try and create the solutions that we need to see on the ground. And I think that's even more pertinent now with the development or the talk of integrated neighbourhood teams. As GP surgeries and GP services, we see everything. We see everything from the patient's first presentation to their last presentation. We see the whole lifespan. We see how they use services, what their feedback is of services. So we no one can see the needs greater than within general practice itself. So the more we empower ourselves to create those solutions, the better for our patients. But actually, it's about us also showing our value to the system. We really can be the solution that the system needs. But we have to be willing to, sometimes innovate, sometimes try things differently. And I think my advice would be, if you spot a problem and you think you can identify a solution, then give it a go. Just try it and see what happens. I mean, that's what we did. And we managed to sort of organically grow a service from nothing into just being a few fragment non-related services, to then uniting them into a model of care that was a really solid model of care, and probably gives a model of care that you might see in the future with more integrated working. So I think it's just being willing to do that. And I mean, the outcome for us was, by doing that work, we noticed that the elderly were previously quite resistant to psychological therapy and talking therapies. So through this model, because we created this frictionless system, we increased the number of elderly patients accessing psychological therapy by over 200%. And we knew that men were a really resistant group as well, and the rates of suicide were highest in men. So that was a group that we really wanted to impact. And the sort of rate of increase of those men accessing psychological therapy was a rise of 165%. So the solution we created actually translated in to a delivery of what we were seeking to achieve.
Do you then track that impact around the rest of the system? So do you talk to your mental health team and the IAP team? Are they noticing a reduction?
Interesting. So talking therapies have a target of the number of patients they need to see. So they want to see patients, because it is a target of theirs that they see a certain number, a certain threshold of patients. So they need these patients, but they are also quite attuned to the fact that they want to be serving an underserved population. So one of talking therapy's problems was the over 75s or over 65s accessing their therapy. They found that a really hard problem to fix. How does talking therapies get more patients through the system of that age group? And they were struggling with that. So this created an immediate solution to them. So this for them became really, really helpful, because this solution then increased the number of those referrals into their system. So what you find is stakeholders become really interested, because if you understand the stakeholders' problems and the stakeholders' concerns, you can help be part of their solution just like they can be part of your solution. So it's completely mutually beneficial. And that's a lot of how we managed to do this. And I think what GPs were finding in the surgeries was, if you put someone through this system, they're less likely to need lots of GP appointments and be told time and time again that you're just going to have to wait and wait and wait for your therapy. So you could actually, although this was a really hard one to prove, you could actually see that people were requiring the GP services less because actually they had a treatment pathway now. They were open and they were going through with that. So you ended up with a benefit. There was no stakeholder that missed out. Everybody had something to gain through that sort of process.
I don't know if I'm being short-sighted. I think it's a fantastic example that, if I understand correctly, you're helping IAP to achieve their target that they get commissioned for. Does that not matter? You know, like, everybody wins, but there are stakeholders that you are supporting, but you're not getting commission, but they still get their item of service. They're still being commissioned. So yes, they love you. Yeah, keep sending those referrals. But I think, how do you show the system that we are financially savvy, we are saving the system money, we're helping other stakeholders contribute to their, you know, like, their contracts? Should no money flow back into general practice, or as long as the patients are being supported, then that's the win. And I feel terrible saying this because I'm a patient. I just want to be seen. But I suppose this podcast is called The Business of Healthcare, and I think that I know the different stakeholders that will be listening, and some will be like, yes, 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 and other people will be like, that sounds great, but if you want general practice to do more things like this, you fund us.
It's a brilliant question, Tara, and it really hones in on the sustainability of doing something like that, doesn't it? Look, and I suppose it depends on, look, we're here to serve patients, so patients are the fundamental priority. So what we need to be aware of is we have to constantly be striving to deliver patients a better service and keep developing our services and keeping the patient at the centre. I think this probably speaks to the future of where healthcare needs to go. And obviously, we've seen the 10-year plan, we've seen the talk of the integrated neighbourhood teams. It's all sensible and it all makes a lot of sense. And I think that's where we need to be. We need to be much more integrated. Patients need to see that because it's better for the patient journey. Like I said, I keep using this word frictionless, but the more frictionless that patient journey is through healthcare, the better for them. But also that journey becomes much more cost effective. It's much more affordable to deliver a frictionless integrated service than it is a siloed, broken service.
Yes.
So there's a system benefit. And I think what's really hard is we're at this moment in time where we know that sort of integration is where it needs to be. It's better for everybody, but there will be the financial question of, well, who's going to fund that? My perspective on this was, look, if it's going to help the patients, let's do it if we can do it. And we could do it, so we did it. I think when you start to see that it's delivering a system benefit, then perhaps we can change that argument and say to the system, and whether that's an ICB or we're going to have new contracts around integrated neighbourhood teams. So those contracts are going to have money. And this is the sort of place where that money may well come from, is to say, look, we have delivered and developed a model here that really works, and it speaks to the problems that our stakeholders are finding, but it's also speaking to a problem that our patients are finding. Here's a solution, but we need it funded now. And actually we can start to create those conversations, those arguments much more readily, and with the evidence that our intervention has made a difference. But it goes back to the same chicken and egg situation, is how do you sell something that's unproven? But how do you prove it if you've not sold it? And it's a really tricky one. So sometimes we've got to go with it. And we often get this in tech as well, where, someone's developed a really good solution, but unless you've tried it and piloted it and shown it works and the proof of concept is right, who's going to buy that? So it is a chicken and egg, and I think sometimes it's about just getting on with it, get the solution in, and I think funding conversations will need to be had about who is going to fund these new integrated models of care. How is that going to work with the new integrated neighbourhood contracts that we're going to see coming later this year or next year?
And do you have the capacity, the expertise in your team to track the system impact?
That's really tricky. Locally, we have, again, that is really tricky, and you do need some BI, business intelligence expertise on board to really understand and track that properly. So I think that would be very hard as an individual organisation, because we wouldn't be privy to what was going on with Talking Therapy's referral numbers. But if you're stakeholders, you have those conversations. So if you speak to the right people, you'll understand and be able to better understand the impact it's having on them. So a lot of this is about having conversations, creating the forum to have those conversations, and understanding each stakeholder and what they're seeing and what they need to see. At the moment, what we're seeing is increased use of population health tools. So, we have access to an online dashboard that gives us some population health information, which sort of encompasses primary care, secondary care data. But again, that's difficult to interpret, sometimes difficult to understand. So I think the future is going to be about, having those conversations with stakeholders, understanding what their data is suggesting to them, and then trying to make some sense of that.
Faris, if people want to get in touch with you, where should we send them?
Oh, LinkedIn is always the place to go these days. So yeah, feel free to contact me and find me on LinkedIn.
Thank you so much. I really appreciate your time.
Excellent. Thanks, Tara.